Manpreet Mundi. I'm honored here to be invited to talk to you about home enteral nutrition, use of peptide-based formulas. These are my disclosures, and I do want to point out that some of the research that I'll be discussing today was funded by Nestle, and we're always grateful for their support. What I really want to do over the next 20 or so minutes is to describe the prevalence and benefits of enteral nutrition, show you how the use of home enteral nutrition has increased over the last few decades, but then really go into data showing that home enteral nutrition intolerance is quite prevalent, and we need to look for ways to guide our patients or consumers on what to do next if they're intolerant to their current formula. And I want to highlight that one option that's really emerging is to use peptide-based formulas. Always like to start my presentations with a patient. In this case, we have a 50-year-old female with a severe reflux who underwent a Nissen fundoplication. She did quite well for a long period of time, but then her symptoms started to return. At this time, she had gained some weight and also had obesity-related complications of diabetes, high blood pressure, sleep apnea. And so because of this, she was then converted to a Roux-en-Y gastric bypass, which you could see the picture in the corner there. But unfortunately, after the Roux-en-Y gastric bypass, she started getting abdominal pain. Dietary changes were attempted to start with, and there was no response. Upper GI was performed as well as an EGD and showed perhaps the gastric pouch was distended and enlarged. So in this setting, she underwent a revision because she really wasn't able to tolerate much oral intake. But after the revision, she kept having the same symptoms: postprandial abdominal pain, so after eating, some nausea, and even vomiting. CT scan was done and showed some fluid collection around the pancreas. EGD was done, and they thought they saw a stricture at the connection between the esophagus and the jejunum there. So that was dilated, but none of this helped in terms of her symptoms, and her weight kept going down. So at this point, just, thinking out loud, what should we do next in terms of nutrition? Do we work with a dietitian and try to switch her to a liquid diet to see if she tolerates that better and there's less nausea, vomiting? Or do we think that oral intake, food through the mouth, is not going to work, so we need to initiate enteral feeding? And then what's the best way to do this? Should we do a nasal tube, a tube that goes from the nose to the intestines? Or should we put in a percutaneous tube, or one that goes directly into the stomach? Or do we think the gut in this case is not going to work and we should try parenteral nutrition? And so whenever we, kind of come to a decision like this, I always go back to my training and some of my mentors, and they always mention, if the gut works, we should use it. And studies, over the last few decades have shown over and over again that there's significant benefit to using the gut if it works, right? And most recently, and I won't go through all of these details with you, there's immune benefit, inflammation, right? But more recently, we're starting to see that there's also benefit to our microbiome, and that can be quite influential with impact throughout the body. And studies, again, as I mentioned, have shown this. This is a study from Burns patients. Meta-analysis combining a number of other studies showing significant benefit in terms of mortality, right, in terms of GI hemorrhage, sepsis, hospital stay, renal failure, pneumonia. We see in the critically ill, number of guidelines and other studies have shown benefit, cost benefit, lower infection rates, right? Dr. McClave led the most recent guidelines and did a meta-analysis through there again, showing benefit of using enteral nutrition, right? So I think if the gut works, we should try our best to use it. That's pretty much the indication for enteral feeds, right? But in situations where we're not able to meet nutritional needs to oral intake, we sometimes have to rely on enteral nutrition or using some sort of tube to provide that. In terms of avoidance, really, the main contraindications are life expectancy that's less than 1 month, or where the GI tract is not functioning, like if you have an obstruction, bleeding, or you have a risk of severe malabsorption that could be found in certain situations. So with this and all of the data that has emerged over the last few decades, we've seen that the use of home enteral nutrition has also increased significantly. This was a study we did where we were able to find Medicare data from 2013 and noted that in the U.S., over 100,000 Americans were on home enteral nutrition being covered by Medicare. We then partnered with 3 of the largest infusion companies, DME providers that were in the U.S., and looked at their ratio of Medicare to non-Medicare. And using this ratio, we were able to estimate that over 437,000 Americans are on enteral nutrition in 2013. We compared this to work by Dr. Lynn Howard and noted that this number had dramatically increased since the 90s. You can see that here, 152,000 or 597 per million, going up to 437,000 and 1,385 per million. So big increase, and I think rightfully so. But what about use of enteral nutrition in people who are post-bariatric surgery? This is our own experience from our center. 72 patients that we found between 2013 and 2018 had initiated home enteral nutrition due to some complication after bariatric surgery. You can see that 86% were female. Most of the patients going through bariatric surgery are female, so this made sense. Most common surgery was Roux-en-Y gastric bypass, and the sleeve has really come on, on its own in the last few years. So it'll be interesting to reanalyze this data in 5 or 10 years and see if this still holds out. Here's the mean age, around 50 at the time of starting enteral nutrition. And the most common route that we use for enteral nutrition was actually a nasal jejunal tube. Other routes that we looked at included putting in a tube directly into what's considered the remnant stomach here, as I'm showing you, versus a nasal gastric tube versus putting in a tube directly into the intestines. So that's with the Roux-en-Y gastric bypass. With a sleeve gastrectomy, again, nasal gastric tube was used in 9% of cases and nasal jejunal tube in 36% of cases. In equally 36% of cases, patients also had a direct tube placed into the jejunum, and then 9% had it directly placed into the stomach. And there's indications for using home enteral nutrition. Nausea and vomiting, similar to our patient, as well as malnutrition, were some of the most common ones that we found. So that's what we did with our patient. We actually, tried enteral feeds through nasal tube. It worked well. And then we went ahead and placed a G-tube into the remnant stomach and started nutrition there, right? And here comes the next question, which is, what formula should we start with? And luckily, we've had a significant advance in the types of formulas that are available in the market. We now have, standard polymeric formulas. Those have always been there. But blenderized tube feeding, and I know Lisa Epp is providing a lecture on this as well and has done so in the past. But that is also something that is emerging along with complete whole food ingredient containing formulas. Right? This is something that needs a lot more exploration to see if there are significant benefits in this population. There's also peptide-based diets or formulas, and I'll use that term interchangeably. But here what happens is that the protein is enzymatically broken down into di and tripeptides. So normally these proteins are long chains of amino acids, but they're broken down into chains of 2 or 3, sometimes even smaller. The lipids are also provided as medium chain triglycerides. So we have long chain triglycerides, which essentially refers to the carbon chain length, and some of the long chain, they'll contain between like 13 and 22 carbons or 24, and then you start to get into very long chain. But some of the medium chain triglycerides, these are between 6 and 12 or 13 carbon lengths. And so I'll share with you some of the benefits that this can have. Then there's also elemental formulas where you're truly having the formula being broken down, so the protein is individual amino acids, right? But when we look at the guidelines, we have the European Society of Parenteral and Enteral Nutrition, the Home Enteral Nutrition Guidelines, again recommend starting with standard commercial formula. The ICU guidelines, both from ESPEN and ASPEN, also recommend starting with standard polymeric formula. And this has been our experience as well. The standard polymeric formulas, those were the ones that we use the most common in our post-bariatric surgery patients. And what we found is that in most cases, we were able to meet their nutritional needs, but complications were quite common. Tube malposition, occlusion, entry site, redness, exudate, or some sort of tube damage, right? These were some of the most common ones that we saw. So in our patient, we started on high protein standard polymeric formula, but unfortunately she called pretty soon after starting and said she was only able to get to about half of what she needed. She started to feel bloated after her feeds, increased abdominal pain. She described it as like this ice pick moving around. She was constipated as well. And so again, what would we do next in this situation? Do we think about changing to a formula with fiber? Do we add some pancreatic enzymes thinking maybe she's not absorbing? Do we consider a peptide-based formula? Switch her to continuous feeds instead of like feeding her breakfast, lunch, and dinner? Or do we change her to parenteral nutrition thinking she has intestinal failure? So let's just pause and kind of look at this concept of enteral nutrition intolerance. And a lot of data exists from the hospitalized patients where it's a lot easier for us to gather this data. In this study, almost 1,888 patients who were critically ill from 167 ICUs were reviewed for their enteral nutrition tolerance. And they noted that almost 30.5%, so almost a third of them, had some complaint of intolerance. And they sort of labeled these as an interruption in enteral nutrition due to a large residual volume, abdominal distension, vomiting, diarrhea, or discomfort. Another study looked at almost 754 hospitalized patients, again broken down into ICU and non-ICU patients, and they saw overall, same thing, about a third experienced intolerance. In the ICU, 36%, non-ICU, 26%. And you could see the difference there. Non-ICU, nausea, vomiting, abdominal pain, distension, diarrhea, a lot more than large residual volume, which we've stopped really using in the ICU. But you can see intolerance in the hospitalized patient is quite prevalent. But what about the home enteral nutrition population? And here we meticulously have gathered kind of our data from our population between January 1st, 2018 and December 31st, 2020. So almost 3 years of data, 1,600 patients. You can see their general breakdown indications, the formulas we're using. But when we looked at this, more than half had some complication at a point in terms of their home enteral nutrition. 34% experienced some complication related to their tube, 20.6% related to their enteral nutrition, and almost 22% metabolic or electrolyte complication, right? When we looked at their tube complications, you could see granulation tissue, infection, leakage, falling out, breaking down, damage. But when we looked at their enteral feeding intolerance symptoms, what do they present with? Nausea, vomiting, diarrhea, constipation, bloating, abdominal pain, reflux symptoms were all quite common, right? So in this situation, we can quickly realize that enteral nutrition intolerance is quite common. And we have to have a skill set to look for like different options that we could provide this patient. And in this situation, we tried quite a bit. We started by changing to fiber-containing formula. We provided the formula slower, lengthening it to 30, 45 minutes per feeding. When none of these worked, we then even started providing the formula continuously, so using a pump and providing it slower. But she continued to have symptoms, right? Gas, bloating, abdominal pain, like I've described before. In fact, when we looked back at her records, she called us over 7 times and sent us multiple in-basket messages. She even went to the emergency department. CT scan was done, and you could imagine the healthcare utilization at this point, right? The CT was essentially unrevealing except for some stool in the colon. Even had a GI consult where they recommended using Miralax to kind of keep things moving and make sure she's not having any issues with constipation that could be contributing to the abdominal pain, gas, or bloating, right? So she's still not tolerating enteral formula. So what do we do now? Do we try and add the pancreatic enzymes? Do we change her to a peptide-based formula, blenderized tube feeding, plant-based formula, refer her to surgery, again, another GI consult, or do we change her to TPN, saying that it's not going to work? And in this situation, we've started to explore using peptide-based formula quite a bit. And as I mentioned before, there's some theoretical benefits, right? One, the protein is broken up into di and tripeptides. And you could see we actually have transporters for that. So there's not a lot of processing that the body has to do to get to this level. It's already been done for that absorption. And in certain situations, like in patients with small bowel, we could see that receptor, the Pepti-1 that I mentioned, it's upregulated. So our body starts to express more of it, when we have situations of malabsorption, such as in the small bowel. The other part is in terms of lipids. As I mentioned, those long chain fatty acids before, they're quite long. They don't mix well with water, right? Oil and water don't mix well. And so what starts to happen is, again, you need a lot of processing. You need to break them down into smaller and smaller particles so that they can be absorbed. And when they are absorbed, as I'm trying to show you here, they then go through quite a bit of processing and get converted into these particles we call chylomicrons. And they don't go to the liver through the portal circulation directly, but instead go through the lymphatics. That takes us all the way to the thoracic duct and they're released into our blood circulation, where they sort of float around and finally reach the liver, right? You compare that to medium chain triglycerides, which are much smaller, don't need that degree of processing, can be readily absorbed and go right to the liver. So more readily absorbed. And when they get to the liver, these medium chain triglycerides, fatty acids, they can go right into the mitochondria and be oxidized. Whereas the long chain, they're too long to cross that double membrane of the mitochondria. So they have to be taken across by this carnitine transport. And again, all that just requires work to get it there. So a lot of theoretical benefits, but what does the clinical data show us? Here's one of the studies in abdominal surgery patients, where they were looking at 19 patients after major abdominal surgery who were then randomized to peptide-based formula through a jejunostomy versus parenteral nutrition. And you can see the big difference there in cost, right? Parenteral nutrition was just more costly, but both were able to meet their nutritional needs. And in the peptide-based formula, most were able to avoid use of parenteral nutrition. Same thing in pancreatitis. They've looked at use of parenteral nutrition, which we rarely do anymore. We try and provide nutrition past the pancreas if we're able to. Again, using peptide-based formula compared to parenteral nutrition in this study, looking at nutrition, looking at how quickly the pancreatitis resolves, you can see no major difference, aside from a major difference in cost, right? So compared to parenteral nutrition, peptide-based formulas have been shown to be just as good, but much, much more cost-effective. But what about compared to standard polymeric formulas, right? In this case, 30 patients, pancreatitis, randomized to either peptide-based or standard polymeric formulas, both through jejunal feeds. And you can see overall tolerance was pretty good for both of them, right? But the big difference was in the length of hospital stay. Much shorter for the peptide-based formula compared to the standard polymeric formula, right? Weight loss was also much less in the peptide-based formula compared to the standard polymeric. This is a study looking at patients with HIV. Again, before many of the drugs we had that can effectively manage. In this situation, you could see compared to standard formula, peptide-based formula led to a weight increase compared to weight loss, right, and lower rates of hospitalization as well. So, a lot of hospital data, a lot of post-surgical data. We wanted to look at, well, what about the home enteral nutrition practice? So we looked at our own practice, looked at patients who were placed on peptide-based formulas between January 1st, 2016 and May 1st, 2018. We had 95 patients in that time frame. 53 of them were started directly and 42 switched from another formula. And here's sort of the baseline data, the primary diagnosis. You could see the differences between those who were started directly on the peptide-based formula versus those who were switched, especially for the indication, right? Those who were started directly were really patients who our team felt were going to have issues with malabsorption, pancreatic insufficiency, where there's a lot of data to show benefit. Those who were switched were really switched because of intolerance. And so this gave us a unique opportunity. Here's sort of the formulas we switched them to, but it gave us a unique opportunity to look at this and to see what happens before and after in this population. And you could see dramatic decrease in symptoms of nausea, diarrhea, almost cut in half. Abdominal pain, cramping dramatically reduced, distension. You can see that patients having no symptoms went from 21 all the way to 49%. But what was really shocking to us, and I think something we just forget in the day-to-day of just, the clinic, we get phone calls, we get in baskets, we see patients, was that healthcare utilization. After switch, dramatic decrease, right? Average number of phone calls dropped. Number of ER visits, you can imagine the cost that's associated with that, right? Number of visits with our own providers. And this is where the data is hard to get to. But when I looked at studies, showing average cost of an ER visit for a GI symptom complaint, you could see it could range anywhere from $2,000 on the way to $5,000, especially if the patient gets admitted or there's a CT scan. I mean, it can be quite costly. So even one of these, if we can avoid them, can pay for a long time of formula, right? Same thing we did for our pediatric population. 30 patients, 21 started directly, 9 switched from another formula. And you could see the background, the baseline characteristics there, indications, the formula we used. But really, when we get back to those same graphs of before and after in those patients who switched, you could see dramatic reduction. Again, very small group. We need bigger, population, but dramatic reduction, diarrhea, nausea, vomiting, complete resolution of abdominal pain, cramping, gas, bloating, constipation. So big difference. Same thing in terms of healthcare utilization. Look at the difference in provider visits, phone calls, ER visits. Again, this is a population compared to the adults with a little bit more ER healthcare utilization. So dramatic reduction there. Other groups have also looked at this. I call this real world data. Mayo's real world too, we like to think. But in this case, they use medical claims data, assess the impact of transition to peptide-based formula in over 1,000 adult home enteral nutrition patients. Again, you could see the breakdown, but this is the key. Same sort of finding. So very reassuring that it confirmed what we found in that reduction before and after in GI distress. And then again, reduction in healthcare utilization as well. Right? Same thing in the pediatric population. You start to see the pattern, right? Dramatic reduction in GI distress, GI symptoms before and after. Same thing with healthcare utilization. And so just to kind of summarize, home enteral nutrition is definitely becoming more prevalent, and I think rightfully so. The data supports this. But when we have, over 400,000 Americans on parenteral nutrition at home, complications are going to arise. So we really need to be well equipped in being able to manage their complications that arise, especially those in terms of intolerance symptoms. And one of those, approaches can be to use peptide-based formulas. And I've shown you the data from our group here, adult. Here's the real-world adult patients, pediatric, and real-world pediatric, so the top are ours, showing that reduction in GI distress with the use of peptide-based formula. So I think in our patient, we perhaps waited too long. This was before the work we had done, but we did finally transition her to a peptide-based formula, and she was able to tolerate it much, much better, met her nutritional needs, and we received this message, which is just, exactly what you want at the start of your day. And she said the symptoms of pain, bloating, gassiness, and general feeding difficulties have all but resolved, starting to feel stronger, have more energy, doing my activities of daily living now without so much effort. I really feel that all of the changes that were made have definitely shown great benefit, and I'm so, so happy. So just a delight to get that message. So with that, thank you so much for your attention, and I'll look forward to answering any questions you may have.